Um, it's my privilege in terms of the next part of the show to introduce my boss and mentor, the Health Commissioner, Dr. Nirav Shah, who you'll see in the bio has a very distinguished career. You may know or may know him personally. He's learned a few things about medicine and healthcare from some places like Harvard and Yale and Geisinger, and where I'm told they know something about healthcare. But it's been really our great fortune that he's brought it back home and applying it here in New York before coming to the health department to NYU. And over the past few years at the health department, he has provided both to me and to our office and to the department generally really endless and unbridled passion, enthusiasm, and leadership on ideas for turning data into information and providing innovation in the way in which we think about problems and the solutions that confront us, and providing a tremendous catalyst for transformation in health and in healthcare. Please welcome Dr. Nirav Shah.
Thanks, Foster. That was a very kind introduction. Much better than the introduction I had a few weeks ago when I was in Buffalo and a family friend introduced me and said, I've known Nirav since he was this high and he hasn't changed a bit. So it's good to be among friends. I, as health commissioner, I'm not allowed to have favorites, but I'm a primary care doc, and I see a lot of friends in the audience. So I hope there's no reporters or others out there, but it's good to be home among friends from Bellevue, from Niagara Falls, from across the state. And what I hope we get out of this is a reaffirmation that what you're doing is exactly the right thing to be doing, and it is the right place to be. What I'm worried about is that we're on the verge of wasting a perfectly good crisis. We know that we're faced with a lot of challenges, and statistics come by all the time that we're short 46,000 primary care doctors by 2020 across the United States. Today in New York, we're short 1,100 primary care doctors. It's not a problem you can put off to another day, like a bad credit card bill or a visit to the in-laws. We got to face it today. We have to figure this out now, while the crisis is still in crisis mode. Haney's did a survey, and they found that 32% of hospitals in New York have had to actually cut back on services as a result of a broader physician shortage. This shortage is absolutely most dire in primary care, and when only 8% of graduating medical students are going into family medicine, that problem isn't going away anytime soon. When you ask folks what the problem in healthcare is, people will sometimes say, yeah, there's a primary care shortage. Others might say it's coordination between primary care and specialists. Others might say medical malpractice. Others might say there's crises of dementia and obesity and other challenges that we're not ready to face. All of those folks are right. If you ask the average Joe on the street or the average employer on the street, what is the problem in healthcare today? What are they going to say? Any guesses? Costs? Can't find a doctor? Access? Yeah. I think you're right. You're all right. I would characterize the thing that I hear most is affordability, is the affordability of healthcare. And we know today that 1% of patients are responsible for 21% of costs, that 5% are responsible for 50% of our costs, that 10% are responsible for 75% of our healthcare costs. Meanwhile, the healthiest 50%, they only cost us 2% of our healthcare spend. How much do we spend on primary care? 5% of our healthcare dollar goes toward primary care. That's not unrelated. Those statistics absolutely have something to do with each other. I'm very worried because my exchange in this state is going really well. We've signed up 330,000 people already, and we're on track to sign up over 1 million over the next few years. When they have that shiny new insurance card, where are they going to go? Yeah, I'm worried, and you should be too. We have to start thinking outside the box. We have to look at what other people have done well. You know, we know that telehealth is a promise, yet unfulfilled. Why have we all gotten on the patient-centered medical home bandwagon? Not only because it works, but people know what they're getting when they pay for a patient-centered medical home that's NCQA designated as level 1, 2, or 3. And all the payers can get on board and say, I know what I'm paying for, I know what I'm going to get, I'm happy to pay for it. That doesn't exist in telehealth. That does not exist in community health workers or other areas where we need, for example, an army of community health workers, I'm sure. We're trying. You know, this is a $250 million project, what you're involved in today. And it has really made a huge difference. It's a chance for us to learn from each other and take what we've done to the next level. We're trying with little programs, a few million for doctors across New York, a few million for practice support awards. But this is so marginal relative to our $120 billion New York State healthcare delivery system. We have a lot to start to think about in terms of where do we sit relative to the new spate of urgent care centers and retail clinics and other things that are cropping up just right outside this hotel, in fact. What is your role? How are you going to survive? How are you going to thrive? How are you going to still provide patient-centered care that's coordinated when the system is actually getting more fragmented on the outside? We're trying to set the bar high, saying you want to be a retail clinic, you got to share the data with everyone, and you got to refer people back to a patient-centered medical home. And same thing along the lines across the new continuum of what is out there in healthcare today. And what does the future hold? Well, I am actually an optimist on what the future holds for us. We've come out recently with something called a New York State Health Innovation Plan. This is a 200-page document that I think should be required reading for everyone in this room. It's on our website. Just Google New York State Health Innovation Plan. The first 23 pages are the executive summary, and if you can't get past that, at least read that. But what is it? It's our roadmap in New York State toward the triple aim. And it's built on 3 foundational elements and 5 pillars. Not rocket science. This is about improving access to care, integrating care, which means behavioral health, physical health across the continuum and other settings. It's about transparency. That ship has already sailed in New York. We know that we have access to all the cost and charge data for every hospital, 1,400 conditions today on our website. It's not going to be long before we have that for every DNTC. And ultimately, the price for every physician. That's happening. We know that the fourth pillar in that plan is about paying for value, not volume. And that's hard. We've been reimbursed by what you do for so long. How do you suddenly start getting paid for outcomes and preventing things from happening in the first place? That's always been the biggest challenge of public health. You don't need public health because there's nothing there. Public health works when nothing happens. Same thing with prevention and ultimately primary care in the future. You're doing your job if nothing happens. And finally, promoting population health as the 5th pillar. And this is something that you'll hear about later today as well, so I'm not going to go into it. Those 5 pillars are built on top of 3 enablers, and those enablers are workforce. Certainly we need to think more broadly about our primary care workforce, physicians, extenders, and the continuum. What can a nurse practitioner actually do on his or her own? It's built on health IT. And we've talked about health IT a lot. 2 days ago, we were very proud to announce that New York State is investing north of $65 million a year on our statewide health information exchange, our SHINY, it's called, the Statewide Health Information Network New York. So you, as a New Yorker, will have your medical records accessible to you from Brooklyn to Buffalo, all on one network, and on top of which we will help build those population health tools. It's going to really enable high quality care. And the third foundational element is evaluation. We always forget about evaluation. It's the afterthought. Oh, by the way, we should see if this actually works. Well, that's not going to be an afterthought. It's going to be built into every single thing we do, so we can create that learning healthcare organization and continually improve. Now, that whole work plan, that State Health Innovation Plan, is actually really about advanced primary care models. So you think you're done now that you're a level 3 NCQA patient-centered medical home? You're just getting started. And what we're doing is we're suggesting both to NCQA and Joint Commission and others that we need, maybe this is necessary, but it's not sufficient. To live in that value-based world, you need much more beyond just a certified EHR, beyond saying that you integrate care, beyond, you have to be able to think and live in an environment of shared savings and capitated payments. And you need to thrive, and your patients need to thrive. So we're working on that together, and we hope that you will also be an active part of that discussion as we think through what the SHIP, the State Health Innovation Plan, actually means in real-time practice across New York. You can get involved, and you can start to learn about measurement. What is it? What is NQF18? Anyone know? Foster, you can't answer. It's an example of where we're trying to get, with 1 Million Hearts, with the CDC, to actually get folks who are undiagnosed hypertensive but meet hypertensive JNC7 guidelines of 2 elevated blood pressures, get those people into care and get people who are in care treated to goal. One example of understanding about measurement at a deeper level than we do otherwise. You have to learn about population health. We talk about it. What do you do to manage your population? Do you have a registry? Do you have nurses or others who actually daily go through it every day and identify opportunities? Practice management has to be taken to a new level. Care coordination has to be taken to a new level. Improved access, patient-centeredness, all of these are terms that we talk about a lot, but now it's time for our A game. In primary care, there is a lot that is quantifiable. The average primary care doc worries about a total of 417 cases of uncontrolled cholesterol, 312 cases of uncontrolled hypertension, 91 cases of uncontrolled diabetes. She spends 10 hours a day dealing with chronic conditions and devotes another 4 to acute problems like infections and injuries. The average primary care doc interacts with 229 physicians across 117 practices, according to a 2009 Annals of Internal Medicine article. But those are only the quantifiable parts of our profession. We can't measure the gratitude that a mother feels when you bring down her child's fever, or the relief a patient experiences when you tell him that his tumor is not cancerous. You can't quantify most of what we do, and that is part of the problem. So, I'm going to leave you with one almost existential question. How do we, in primary care, navigate the commercialization of medicine, the commoditization of what we're doing in primary care? Is it a widget that you're delivering? Which will allow us to talk in the terms of the new accountability. How do we still retain the autonomy of what we do and the central doctor-patient relationship that makes being a physician still a profession or a calling and not just a job and a paycheck? If you can answer that, we're done. Thank you.